As a clinician, I'm very well aware of how difficult it can be in a time-limited situation to interpret an insulin pump upload. So what I'd like to provide is a simple approach to interpreting a CareLink report for a patient on a Medtronic MiniMed 670G insulin pump system. And it is as simple as ABC, A standing for auto mode, B for behaviours, and C for carb ratios. So time in range, which refers to blood glucose levels 3.9 to 10 millimoles per litre, has been validated as an outcome measure for patients with type 1 diabetes. We know now that for every 10% drop in time in range, the risk of diabetes-related complications increases significantly, with diabetic retinopathy increasing by 64% and microalbuminuria increasing by 40%. There has been a stepwise improvement in time in range with intensification of insulin therapy, with 45% time in range for patients on multiple daily injections with self-monitored blood glucose, improving with continuous glucose monitoring and multiple daily injections to 51%. Earlier insulin pumps with CGM improved to 55% time in range. There was a big jump with predictive low glucose management up to 65% time in range. And now with the MiniMed 670G system utilising insulin pump therapy combined with hybrid closed loop technology, that has improved to 72% time in range. The auto-basal as part of the hybrid closed loop has had an impact in this time in range number, with a 26% reduction in glucose values greater than 10% and 34% reduction in glucose values less than 3.9 millimoles per litre, resulting in an extra 2.5 hours per day when auto mode is on of time in range between 3.9 to 10 millimoles per litre. And this translates in real numbers to an extra 38 days per year of time in range when auto mode is switched on. And this, I'm sure you'd agree, is actually a very significant thing for patients living with type 1 diabetes. So let's move on now to how we can easily interpret a CareLink report for patients on a Medtronic MiniMed 670G system. Our first goal is to look at auto mode, so step A, and our goal is to maximise the patient's time spent in auto mode. This gives the patient increased time in range and advanced protection from lows and highs due to the self-adjusting basal, which is part of the hybrid closed loop technology. Our next step, step B, looking at behaviours, is to encourage our patients to use the right behaviours to achieve the goal of staying in auto mode. So we're avoiding exits from auto mode by demonstrating the right behaviours. We want our patients to bolus before food, at least 15 minutes before they eat. And in fact, that might change in patients on FIAS who are often bolusing at the beginning of the meal. We also want the patients to be calibrating their sensor at least 3 times per day. And in fact, the more fingerstick glucose levels they do, the better. But they must calibrate at least 3 times per day so that there are no exits from auto mode. And going on to step C, looking at carb ratios, we want to be optimising carbohydrate ratios when we're seeing patients. So if the patient is experiencing highs or lows following meals, we want to adjust their carbohydrate ratios by 20%. So importantly, in this upload, you can see that this patient is in fact experiencing hyperglycemia after lunch on most days. So we want to strengthen the carbohydrate ratio with lunch. You can see on one occasion that the patient on the Thursday has not bolused pre-meal, and that is likely why they have become hyperglycemic after lunch on that day, but on the other days they're still experiencing some hyperglycemia following lunch, so we want to strengthen their carb ratio with lunch by 10 to 20%. The recommendation is that we start with the assessment and progress report, which is a simplified report which gives a lot of information on one page and therefore will help minimise the time you have to spend doing this. So looking initially at statistics, this will tell us how much time the patient has spent in auto mode, which we're aiming for greater than 80%. It will tell us how many calibrations per day the patient is doing, and in this report the patient's doing adequate calibrations. It will also tell us how much sensor wear the patient has, with the aim of keeping the patient in auto mode for as long as possible each day. After looking at that summary, we'll be looking at the auto mode exits. So this will tell us how many exits from auto mode the patient's had and the reasons for this, which will enable us to counsel the patient about better utilisation of the system. And next we look at time in range, time spent high and time spent low. And we use the two graphs A and B to compare with one another. Our goal is that each patient spends greater than 70% of the time in the range between 3.9 and 10. We also want as little time spent low as possible, so with a goal of less than 3% time spent between 3 and 3.8 millimoles per litre, and a goal of less than 1% of time spent below 3 millimoles per litre. Next, we can look at the percentile comparison trace, which will show us, according to time of day, if there are any patterns. So this will show us the overnight and post meals. So overall, we're aiming for greater than 80% of the time in auto mode, greater than 70% of the time spent in range, less than 3% of the time spent between 3 and 3.8, and less than 1% of the time spent less than 3. So in summary, the three main steps to enable simple interpretation of the CareLink reports for the Medtronic MiniMed 670G system is keep it simple, A, B, and C. A, auto mode, maximising the time the patient spends in auto mode. B is for behaviours. We want the patient to be bolusing for carbs before meals and calibrating their sensor at least 3 times per day. And C stands for carb ratios. So we want to optimise the carb ratio to minimise post-meal hypo and hyperglycemia. So now I'd like to move on to a couple of case studies. One example of a patient who is utilising the system very well despite being new to the system, and another example of a patient who has some troubleshooting to do. So my first patient is a 60-year-old man who works as an IT consultant. He has had type 1 diabetes for a number of years, but really has minimal other medical problems. He has been using insulin pump therapy, previously the Medtronic MiniMed 640G system, for a number of years, so is familiar to pump therapy, and also pump therapy is good for him as he has a background in IT and appreciates the technology. He recently started on the 670G with continuous glucose monitoring, so he's utilising the hybrid closed loop technology. And you can see really he's doing very well indeed. He's spending 100% of the time in auto mode with only 2 minor exits, which we'll look at shortly. His sensor wear is 94%. And he's calibrating very regularly 7 times per day. This has given him an estimated A1C of 6.3%. So next, looking at the auto mode exits, he's had 2 minor exits, one which was very brief because there was no sensor glucose value being able to be picked up, and the other because he'd reached maximum delivery in auto mode for a period of time following inadequate carbohydrate counting with meals. He is spending 88% of the time in range, which has clearly met our goal, and there is no time spent hypoglycemic and only 12% of the time high. And looking at the percentile comparison, he's very tightly controlled overnight with some variability following meals, but no clear problems with regular hyperglycemia. Going on to the next slide, if we look at the carb boluses, he is clearly following the advice of bolusing before eating. He's had excellent diabetes education and his pump behaviours are excellent with plenty of calibrations and bolusing before food. Looking at his day-to-day glucose profile, there have been a couple of issues which have actually related more to carbohydrate counting, but there is no clear one meal which stands out as being a problem. So for this reason, his carb boluses have not been altered, but he has been counselled about carb counting. So this is a patient new to the system with previous pump experience who is utilising the system very effectively. Going on to the next patient, this is a 49-year-old man with a past history of very long-term type 1 diabetes. When he initially came to me, he was on multiple daily injections with HbA1cs very suboptimally controlled, generally averaging around 10 to 11%. He also has a past history of Graves' disease. He is obese with dyslipidemia and hypertension, so he is on a number of other medications. He initially commenced pump therapy several years ago and has been using the 640G system. His HbA1cs remained suboptimal, but did improve to the around 8.5% generally. And he recently commenced and upgraded to the 670G insulin pump system. He has been using this with full-time sensing, and he is wearing his sensor and has met the criterion for greater than 80% of time in auto mode. He's also calibrating regularly, as you can see, between 5 and 6 times per day. He has, however, had a number of auto mode exits. 2 of these were due to a high sensor glucose. 1 was due to maximum delivery on auto mode, 1 for minimum delivery, 1 for no sensor glucose values, and 1 because auto mode was disabled by him. So this is a bit of a red flag, and you can see that in fact the time spent in range is well below our aim of greater than 70%. He has met the aim for hypoglycemia, however, with minimal time spent hypoglycemic. He has a number of episodes of hyperglycemia which are evident on both the time in range graph as well as the percentile comparison. So going on to look at his behaviours, it becomes quite evident when we look at the day-to-day that he is not bolusing regularly before meals, and in fact there are not many boluses at all for food. So you can see that the patient is averaging 2 to 3 meals per day and not many carbs at all. And when you take a history, he is in fact eating very regularly and often not bolusing for meals, which is likely to be the major issue in this situation. This is also evident on his day-to-day comparison, where although there is quite a bit of dysglycemia, it seems that this is probably related to the patient not bolusing before meals and also not bolusing for food, which has led to dysglycemia, and the algorithm just can't keep up with the fact that the patient is not bolusing for carbs. So on this occasion, the carb ratios were not altered, but in fact the patient was counselled at length regarding bolusing before meals, bolusing for meals and snacks, and carb counting. And that is likely to lead to significant improvement. And after he's bolusing regularly, we can then assess the carb ratios and alter them as required. So that's a brief summary for simplifying interpretation of CareLink reports for the Medtronic MiniMed 670G system. We want you to keep it simple to enable improvements in patients' glycemic control and time in range on the 670G system. So just remember A, B, C, maximise the time in auto mode, bolus for carbs before meals and calibrate the sensor 3 times per day, and optimise the carb ratios to minimise post-meal highs and lows for patients on this system. Thank you.